Hi, everyone. Good afternoon, Dr. V.
Hi, Dr. Horn.
Thanks for joining us.
Yes, welcome to our webinar. So today we've got a good topic, intra-abdominal infections. I don't think we've gone over intra-abdominal infections before, but we certainly get a lot of questions about it.
We have done in limited amount, but we were going to go into detail this time. And there's a new guidelines, not so new in 2017. There's a surgical guideline, and we thought it'll be good to kind of review and go over it.
So if you have any questions, you can go ahead and type into the chat. We have a lot of topics, so if you have any questions at all, type it in the chat and we'll address any questions you have.
So this is the newish surgical guideline. It was published in 2017. It was interesting. I was watching before this came about. When we had the last one, it was in 2010. So this is the newer one, and this has more of like antimicrobial choices. How do you get source control? How long to treat antibiotic if you have intra-abdominal infection? So we're going to kind of review all those topics. So in this paper, this was a really nice study. What they did was they looked at about 4,000 patients in 132 hospitals worldwide, and they wanted to see what are the top intra-abdominal infection cases that we see in the hospital setting on a regular basis. So one of the common one was appendicitis. Then cholecystitis are two big ones. Then, of course, you had a lot of intra-abdominal infection because of post-operative, diverticulitis perforation, duodenal perforation, lots of diverticulitis again. So other intra-abdominal ones, but the two big ones that worldwide, including in the United States, that we see a lot is cholecystitis and appendicitis.
Yeah, and so there are a lot of different types of abdominal infections. We're going to not go over each one in great detail. This isn't meant to be comprehensive with every type of infection, but we more importantly, we'd like to go over kind of a foundation or kind of how we think of abdominal infections and kind of, where to start and what kind of, how to go about, what's the next step? What is the next step in this type of infection? And what are some of the overall goals of treatment for abdominal infections?
And a lot of times, even if you have different types of abdominal infection, it ends up being pretty much the same type of treatment too.
Right.
Even if it's in the liver or kidney. So it's kind of nice to kind of learn that.
Yeah, I think it's, when it comes to an abscess, depending what organ system it's in, the approach is going to be the same.
Yeah.
Yep.
So in this table, they talk about factors identifying patients with intra-abdominal infections who are at high risk. So when patients have, higher risk factor, they have increased risk for intra-abdominal infection, bad outcomes. So if you're age greater than 70, if you have malignancy, a lot of cardiovascular compromise, so not good blood flow, ischemic bowel, liver disease, cirrhosis, kidney disease, hypoalbuminemia, so malnutrition, all those put you at really high risk for having intra-abdominal infection and bad outcomes. And then I would say secondarily, extent of infection, adequacy of initial source control. Diffuse generalized peritonitis is kind of hard because it's everywhere. It's not just one little abscess. If we delay in source control, inability to achieve source control, of resistant organisms, all that puts that intra-abdominal infection at a higher risk category. Would you say, what do you think about that?
Yeah. So when I think of abdominal infections, I think of two things. One is going to be how severe is it? Is it essentially moderate or high severity? I never say mild, I just say moderate or high. So it's severity and then also source control. And so a lot of these things, it has on here inability to achieve source control. And that's kind of how I think of it, because some of these things will make it higher or harder to achieve source control, like malignancy or, especially like what you're saying about if it's all over, if it's diffuse and it's hard to get rid of. So I think we'll see that a little bit when it comes to severity and source control. And yeah, I think so who is higher risk? And sometimes the patients will say that. They'll say, why did this happen to me? Or what are my risk factors? And these are the kind of things I think about. Or when I see the patient, I think, wow, they have a lot of things that, are directly related to putting them at high risk.
Yeah, agree.
Oh, and then this is, so the antibiotics. So I think we can talk about the antibiotics in general, and then when we talk about specific organ systems, then we can talk about specific antibiotics. But in general, this is kind of how I think about it. This is the severity. So it's either moderate severity or high, and then you've either got a single agent antibiotic or combination antibiotic. And really what that depends on is, does the antibiotic cover anaerobes? And so if it covers anaerobes, then it can be in the single agent category. Otherwise, it's going to be an antibiotic plus metronidazole to cover for anaerobes. So
yeah. And when you look at here, even though this is kind of part of the guidelines, I'm always like, when I don't have to use so broad, you know what I mean? So like ertapenem is great, but it's so broad. So my go-to is, if I have to use anaerobic coverage, I do like ceftriaxone and Flagyl, for example.
Yep, that's mine too.
Yeah.
Yep.
So just so that and I also don't like moxiflox, any type of fluoroquinolones, because of all the side effects. It's there, it's on the guidelines. But if you could get away with a little bit of a less broader one, I tend to do that.
Yeah, and moxifloxacin is also very expensive.
Yeah.
So a lot of hospitals, instead of having like Levo and Cipro on their formulary for their hospital, thank you. They'll only have one. And so they might have just levofloxacin.
Yeah.
And so levofloxacin plus metronidazole might be good. And this is all dependent really on your antibiogram, but and how sick they are, right? So but yes, when they come in, I would usually do ceftriaxone plus metronidazole. And then if they're really sick, I consider something like Zosyn, or even cefepime metronidazole would be okay.
I think those type of combination, and we'll tell you when to add a little bit more broader coverage, but go-to would be ceftriaxone, metronidazole, moderate, high Zosyn, piptazole, cefepime, Flagyl. That'll kind of hit all the gut flora. Just be aware, like if the patient has past history of Pseudomonas in their belly, then you have to, of course, adjust it. But this is empiric treatment if they have no high risk factor.
Yeah, so this would be a good chart. The one question we sometimes get is, what if they have an allergy? Right? So if they have an allergy, so if you're planning on giving them like a cephalosporin and they have an allergy, what's the next best drug? Well, it depends on how severe it is. But if they have a beta-lactam, like a cephalosporin allergy, then a fluoroquinolone plus metronidazole might be okay.
Just my personal preference too.
Yeah.
If you're going to use fluoroquinolones, I really like levofloxacin, then ciprofloxacin for gut.
That's good.
And the reason for that is levofloxacin has more strep coverage. So in your gut, you have more like strep viridans and other strep. So I prefer using levoflagyl for the gut than ciproflagyl. What do you?
Yeah. I prefer Levo just in general to Cipro, just because it has more coverage and it's once daily.
Yeah.
So I like Levo, and that's what our hospital carries is Levo instead of Cipro, or instead of carrying both. Yeah, I think Levo is good. Yeah, I think now sometimes when people are, if they have an allergy to a penicillin like piperacillin, then you kind of think of what else can I give? A fluoroquinolone plus metronidazole would work, or
even a carbapenem is okay. If they have true allergy to cephalosporin and they're in like bad shape, use a carbapenem, right?
And so even if they have allergies to penicillin, or they have like a cephalosporin allergy, you can still use in the majority of the time a carbapenem, and so they'll do fine on a carbapenem. Aztreonam, I don't use aztreonam very much, and I don't really trust it for high severity.
Aztreonam is okay. The only problem is it has no gram positive coverage. It's only gram negative. and it's very expensive too. So like if you have other options,
Yeah.
I don't use it a lot.
Yeah, I try not to, just
Yes.
because I feel like it's a weak,
Yeah.
weaker cut in the same way that you'll see that I guess we don't have Unison, we don't have ampicillin sulbactam on here. I wouldn't use ampicillin sulbactam for a high severity infection.
If you know susceptibility, the organism, and if it's susceptible, it's okay. But in an antibiogram, for example, E. coli is pretty resistant to ampicillin. So I wouldn't use it empirically without knowing the organism and susceptibility. Yeah.
All right.
And this table, when we send the slides, you could look at it later. This is just from the guidelines as well. It just recommends when you have other organisms that grow from the abscess, what kind of agents should you use? So like if you have Enterococcus fecalis, and that's playing a role, then making sure it's covered by Zosyn or Unison. Oh, if you need, you could add vancomycin. If you have Enterococcus faecium and you're worried about VRE, you could do daptomycin or linezolid. So this table is just really nice to show you if you have a resistant organism, then you have to expand your coverage. ESBL, carbapenem, KPC producing, you need to have the newer agents. So it's a good reference for you all to look at later when we send the slides.
Yeah, I think that's great, because the other one is the common patients you see, and then this is a good reference for what more should you be worried about, what more should you be giving for patients with resistance.
So go ahead.
Oh, sorry, this is low risk patients with and community acquired intra-abdominal infections, and so treat lower risk patients with narrower spectrum antimicrobial agents. So in general, you want to choose the most narrow spectrum antibiotic. So you're going to cover gram-negative Enterobacteriaceae, so a lot of gut stuff, strep, and then obligate anaerobic microorganisms associated with these infections. So, in general, you want to think of gut stuff, which is going to be a lot of gram-negative rods, a lot of gram-negatives, gram-positives, and anaerobes. And so it's just essentially broad coverage.
Yeah, and Enterobacteriaceae species, when they say that, it means like E. coli, Proteus, Klebsiella, and then streptococci, it could be like strep viridin, strep, and then when they say a lot of anaerobes, a lot of times there's so much anaerobes in our stool, but one of the big ones we always see is B. frag, Bacteroides. So just making sure we cover for all those varieties.
Yeah, and it says, do not routinely use broad spectrum antibiotics to cover anti-pseudomonal, anti-enterococcus, and then antifungal. And that's, so an example of this would be like ceftriaxone plus metronidazole. So that's what we use frequently. And it doesn't cover Pseudomonas, it doesn't cover Enterococcus, and then we don't commonly add antifungals. We'll talk more about fungal agents in a minute, but ceftriaxone, metronidazole is what we use
for low risk.
Typically, right, for low risk, and so you don't need to cover everything.
Yeah. And then, if you're going to, here's the two agents, but also if you need an oral agent, right? Let's say instead of IV, ceftonir or ceprodoxime, third generation cephalosporin. I kind of really like ceprodoxime because it has bioavailability like 60% versus like ceftonir like 40. So if you need some oral agent, you could do ceprodoxime and Flagyl. And Flagyl is fantastic, over 90% bioavailable. You take it by mouth, right? So like if a patient is doing well and you just need oral agent, you could do a third generation cephalosporin and Flagyl. You could do augmentin if the organism is susceptible. Of course, then your other alternative is levoflagell, like we talked about.
Yeah, so if the patient, let's say patient's getting better, you want to give a couple more days of antibiotics, like for your duration of therapy. Or let's say you grew out an E. coli and has some resistance, but it's susceptible to ceftriaxone, then ceftonir or ceprodoxime would be a good option. So if it's susceptible to ceftriaxone, so if you're E. coli or Klebsiella, if ceftriaxone would work, then if you're looking for a pill option, you can choose another cephalosporin that's in the same third generation.
Yeah.
And then consider use of levofloxacin plus metronidazole as an alternative. Yeah, so I like beta-lactams, just like what you're saying.
Yeah. I
Beta-lactams.
put a little in there going allergy. So if you're worried about allergy, if this is your last resort, we really stay away from fluoroquinolones.
Yeah, if possible,
Yes.
then yeah, and if there's a beta-lactam choice, then that would be great. And then higher risk patients, you'd want to go more broad spectrum to include more things if the patient's really not doing well or continuing to get worse. So here it says piperacillin tazobactam. You can use carbapenems or cefepime. So cefepime is going to have pseudomonal coverage, whereas ceftriaxone won't have that coverage. So cefepime will cover a little bit more than ceftriaxone. And then consider use of aztreonam plus metronidazole plus vancomycin if they have severe allergies.
Yeah. And then other agents that cover enterococcus. So usually in the ID world, if enterococcus shows up, it's part of a gut flora. So a lot of times we say it's not causing infection, but in some patients, it really causes infection. So if you're worried about it being the main pathogen causing this infection, so for enterococcus, depending on the susceptibility, ampicillin and something, or vancomycin, ozostin covers enterococcus really well if it's a, so just making sure we cover for that is important.
And then as far as resistant gram-negative organisms, so if you're wondering, which patients would be at risk for resistant gram-negatives, so if they've gotten a lot of broad-spectrum antibiotics, prolonged hospitalizations, multiple invasive interventions, so a lot of surgical procedures, previously colonized or infected with a resistant gram-negative. So that's why when we'll get a new consult, I'll go through all the old cultures and see if they've had an organism with a lot of resistance in the past. And usually when I'm looking at old stuff, the resident or the fellow, they'll say, oh, that's really old, that's not relevant. Well, it might be if it has a lot of resistance, right? So if they in the past they grew out an ESBL and the patient just came to the hospital and they're very sick, then they'll say, oh, that was a year ago. And it might be, usually it doesn't, usually it may not be relevant, but if it's something like an ESBL and the patient's in the ICU on a couple pressors, then
it's relevant.
It's relevant.
Yeah.
Right. Yeah.
And then I would say, using your own antibiogram too, looking at your resistant pattern is very important too. If you're empirically treating and the patient is not doing well, that'll be really important. Personally, some of the cases I see is like chronic intra-abdominal abscesses that is taking so long to resolve. I really struggle when our patients have had like necrotizing pancreatitis infections and they're loculated. We're trying to drain, and then the nice bacteria gets more and more resistant. Yeah. So like it does happen, not always. So just follow the culture. And then I always kind of careful, because if our patients have been struggling with this for months now, and all of a sudden they're like doing really bad and septic shock, then I go broader because now they're exposed to all these antibiotics.
Yeah, and that's a call sometimes that we get. They'll say the patient's been on this for a while, they're getting worse. And the question is essentially, what's the next step? What is the next escalation of treatment that you go to? Yeah. And as far as duration of antibiotics, we talk a lot about shorter is better and reducing the number of days of antibiotics. And it keeps getting shorter and shorter, especially with abdominal infections, but all types of infections is getting shorter. But the main thing is that, you don't have to give 2 or 3 weeks for abdominal. If someone has an infection, you don't have to continue on with weeks and weeks. It gets shorter and shorter, and that makes everybody a little bit uncomfortable. But
these recommendations are straight from the guidelines. So they say if you have severe necrotizing pancreatitis, but you're not worried about infection, they say don't start an antibiotic. Consider deferral of antibiotic for low-risk patient with uncomplicated acute colonic diverticulitis. We'll talk a little bit more about diverticulitis. Again, shorter is better for diverticulitis too, but this is really interesting. Limit antibiotic therapy for no more than 24 hours, okay? So they're saying for no more than 24 hours for traumatic bowel perforation operated within 12 hours. So let's say somebody's coming with like acute stuff and you're doing operations really quickly. They say you don't have to continue antibiotics for a long time because you're getting source control. So bowel perf, you got quick operation done, 24 hours, you could stop. Gastroduodenal perforation, if you got good source control and surgery, they say 24 hours antibiotic. Acute gangrenous appendicitis, in the absence of perforation, it's intact, there's no perforation, 24 hours. You operated, you took it out. Acute cholecystitis, again, in the absence of perforation, they say 24 hours. And ischemia, non-perforated bowel, so like, not blood flow, but it's not infected, 24 hours. So it's really good to know this, because if you have good source control, good surgery immediately, you don't need prolonged antimicrobial therapy in these particular cases.
And then limit antimicrobial therapy to 4 days for inpatients who have had adequate source control. Consider limiting antimicrobials to 5 to 7 days in patients without source control. So ideally, so what source control means is that let's say you have an abscess, or let's say you have cholecystitis. So you have an infected gallbladder. Once the gallbladder is out, you have source control, and you can say the infection is no longer present, your source control, and then you don't need to continue antibiotics for a long course, since they had an infected gallbladder and now they don't have an infected gallbladder. The infection's gone, right?
And one of the, like in the prior slides, what they're saying is also, if you have appendicitis or gallbladder, it's infected, but it's staying together. There's no spillage.
Yes.
Yeah. It's infected, but they're together. You could stop after 24 hours. It's kind of hard to convince people, but I've seen some people do that.
Yeah.
But if it's here, but it's still some stuff and you still cleaned it out, then you could do, it looks like 4 to 7 days short course.
Or let's say you have an abscess and then you place a drain and the drain is draining the abscess. Then you could say you have source control because, you're getting rid of the source of the infection essentially. So, and that's what I meant earlier when I was saying source control and severity of infection. So reassess patients who do not fully respond to antimicrobial therapy within 5 to 7 days for a potential source control intervention. So generally when we reevaluate it, a lot of the times that's going to be imaging to make sure that, you have a source of the imaging, or sorry, you have a source of the infection and it's getting drained or it's taken care of, or it's not continuing to get worse and worse without control. And let's see, so consider limiting antimicrobial therapy to 7 days in patients with secondary bacteremia. So, and bacteremia, this is an important point too, is that if someone's bacteremic, let's say someone has an infected gallbladder and then they're bacteremic. So once the gallbladder is out, you no longer have to worry about the gallbladder. But if they were bacteremic, you might want to treat for bacteremia.
Yeah. Yeah, that's true, because that infection is still there. So we need to finish the course. And again, always remember, this is guidelines. Sometimes some patients you might need longer. So this is just a general guideline. Yeah.
Oh, so do I need fungal coverage? So this is a common question also. This is common with the surgeons as well, where they'll have a patient with an abdominal infection or abdominal surgery, and then do I need to start something for fungus, since fungus is common in the gut? So in general, empiric antifungal therapy for Canada is not recommended for adults and pediatric patients with community-acquired intra-abdominal infections. So earlier when we were talking about our antibiotic choices, those are the antibiotics, and we don't add an antifungal to that. We'll just keep ceftriaxone, metronidazole. You don't need to add fluconazole or micafungin or anything to that. There are some exceptions. So the patients that would be at high risk for Candida in the blood would be prolonged antibiotics. So if they've been on broad spectrum antibiotics for a long time, it kills a lot of the bacteria, and then you get overgrowth of the fungal. And here's central venous catheters. So TPN, neutropenia, bone marrow transplant. These are all things that put people at high risk for fungus in the blood. burns, solid organ transplant, implanted prosthetic devices like a heart valve,
Yeah.
immunosuppressed agents, and prolonged ICU stay. So, and those are some of the main ones. Those, when I think of a patient and someone will say, do I need to add an antifungal? I kind of go through, have they had prolonged antibiotics, like broad spectrum antibiotics, prolonged ICU stay, TPN. Another one that I think of would be steroids.
Yeah.
If they've been having a lot of steroids, that would be another one. And so that's kind of what I think about as kind of, I think it's better for its negative predictive value.
Yeah. And there's actually a Candida infection calculator too. So,
Oh, that's right.
yeah,
That's
there's
good.
some papers that if you're a high risk center like trauma, transplant, you could actually use a Candida score to see how high are they and do they need empirically antifungal if they're like not doing well in the ICU. So that's another tool as well.
Yeah, and that's a really good point. And if a patient's all of a sudden you've had them on antibiotics and all of a sudden they're getting worse, and you look and you say, wow, I have them on really good broad antibiotics,
Yeah.
but I don't have them on fungal coverage. And that's generally, and fungus will grow from just your standard blood cultures.
So then when should you give, right? So let's say you have a patient who's not doing well. They're in the ICU, they're not getting better. So people who are, upper GI perforation. So in our GI tract, especially in the upper area, Candida is like a normal flora, they hang out. So if you have like duodenal perforation, gut, gastric perforation, recurrent bowel perforation, surgically treated pancreatitis, those who have received, long course of antimicrobials, and also those who have had Candida, heavily colonized in other sites, right? So if you're worried about a patient, they're not doing well, they have some of these criteria, then I think it's okay to add antifungal. But when you do antifungal, if it's a severe case, as you know, we have lots of different Candida species, and they're, Candida glabrata, for example, it's really becoming more common in hospital setting, and they're not susceptible to fluconazole. So if you worry about a person on top of having antibiotic to add antifungal, start with the echinocandin, like micafungin, that's what in our formulary. But if they're unstable patient, but if they're stable, you could add fluconazole and wait for the culture and susceptibility. How do you usually do it?
Yeah, that's exactly what I do. So if they're unstable, so if it's like sepsis, septic shock, and I'm trying to think of everything to give them, it's always okay to give them a dose or two, and see how they do. I had a call, I think it was last weekend, and they said, I just want to discuss micafungin use. There was a patient, and we discussed the patient, and they were essentially septic shock. And I said, it's okay to use micafungin right now. It's definitely okay to start it and then de-escalate when possible.
Yeah.
So anytime you're really worried about a patient, when they're septic shock, it's always okay to start it and then de-escalate quickly would be the stewardship recommendation. But generally for abdominal infections, I don't start something. It depends. It's like you said, all dependent on the patient. Yeah,
exactly. If they're crashing, if they have history of all of these other stuff, history of colonization with Candida, it's okay to start. They're stable on the floor, I think you could reassess, and if they grow, you could start with fluconazole. So it just knowing where they are.
And I really agree with what you just said. If it grows, start with fluconazole. So if the patient's, if they're maybe having a high white count, or maybe, something, you can tell something isn't right, you could start with fluconazole, and then you could take blood cultures, start with fluconazole, and then see if you're able to identify something. I think, the books and stuff would say, what if you're going to choose between fluconazole and like micafungin, they would say, how sick is the patient? And then at your institution, what are the rates of Candida that's resistant? But that's a little more difficult. We don't always know that right off the bat, of course.
So anytime I see Candida in the blood, I start with echinocandin because I'm worried about, then I have to figure out what species. But if it's in the wound or if it's in an abscess and they're stable, fluconazole might be okay. So just Clinical judgment at the
And,
bedside.
and never ignore it.
Yes.
Another one that we see in stewardship is that they'll say, oh, they're not doing too, like, should I worry about this at this Canada grew from the blood?
Oh yeah, never.
Is
It's
that-
always real.
Is that important? Yeah. Yeah. Yes, it is.
So diverticulitis, like we showed the data earlier, diverticulitis is one of the most common infections that we see in a hospital setting. This is a really nice study. Annually 1.9 million outpatient visit and almost 200,000 inpatient admission for diverticulitis. So it's a big reason we have to work on our diet and all the other stuff too. But it's a big burden, and the incidence in individuals is about 40 to 49 years old has increased. So younger people are now getting more and more diverticulitis. So that's important to kind of keep an eye out too. And main thing from this approach is that the regimen usually includes broad spectrum agent with gram-negative and anaerobe. So like something like ceftriaxone, Flagyl. In an outpatient setting, treatment of mild uncomplicated divertic mostly includes either a combination of oral, so beta-lactam, or you could do fluoroquinolone with Flagyl if you can't use a beta-lactam. And they also say duration of treatment is usually 4 to 7 days. So mild cases, they really want you to do a shorter duration now. In our practice, duration therapy is based on general health status, immune status, severity, CT findings, and patient expectation. So mild diverticulitis, no perforation, no abscess formation, short course is okay.
And then as far as intra-abdominal abscesses, if a patient comes in with an abscess, and in general, no matter what organ system it's in, if they have an abscess that's seen on CT scan, then, people will ask, well, what antibiotic should I give? What should I do? Ideally, if you can get a CT guided drain placed. So, and that would be the source control. So if you can put a drain in, drain the abscess and also get cultures of it before giving antibiotics, then that would be ideal. If they come in and they're sepsis, septic shock, I wouldn't say wait. I wouldn't recommend waiting to get a drain placed. But if they come in, let's say they come in late at night, you do a CT scan, you see they have a hepatic abscess, then if they're doing okay, and let's say, and what I mean is they don't have hypotension, they don't look like they're in sepsis. It sounds like they've been having pain there for a week or two. It would be okay until waiting till morning to place a drain, but I have a low threshold to give them antibiotics, because even if you put that drain in, you're not probably going to sterilize it by morning. So it's okay. I don't want to say don't give people antibiotics,
Yes.
but if you feel like it's been there for a long time and you're able to get a drain placed, in the next day or so, then that when you place the drain, get cultures of it, and then allow it, the fluid that's in there to drain out.
Yeah.
Oh, sorry. So here's some pictures of some drains. We have here's a Jackson Pratt drain here, and then a Penrose drain. It's just essentially allowing it to come out. So these would be like if this Jackson Pratt were into an organ system, or if it was just in the abdomen. And then this one here is usually more for superficial abscesses and things. Here's another picture. Usually you squeeze this and it will have some suction for the fluid that's there. And then here's another picture of this is an IR guided drain placement. This is a renal abscess. So if someone comes in with an abscess in a kidney, this is a picture of the abscess. And then this is the needle going in. So the interventional radiologist will put a needle right into it with using a CT scan as their guide, and then they'll slide the drain over the needle and remove the needle, or over the guide wire. They'll put a guide wire in. Yeah.
Renal abscesses, and just so if you all ever get kidney abscesses, it's very serious. If it's large and small abscesses, you could kind of treat. But if it's large abscess, you have to be very aggressively drain it, because kidney abscesses, If it gets uncontrolled, you could actually lose the kidney. They might have to do nephrectomy. So it's really important to manage these cases very aggressively and drain those abscesses and treat them appropriately.
Yeah, and the abscess, so it's the pH is really low in the abscess, and so the antibiotics, when they get into that pH, it turns off the antibiotics.
Yeah, it's
Even if they're
very
able to,
acidic.
even if they're able to get into there, yeah.
Yeah.
So the antibiotics, so a lot of the times, just like a skin abscess, it needs to be drained. And here we just want to show some pictures of, some drains. So here's a gallbladder, and if the patient is very sick, or if they have a lot of comorbidities and they're not able to have the gallbladder out, sometimes they'll put in a drain into the gallbladder to get source control. Then here's another abdominal abscess with a pigtail drain that's in there that's draining.
And in the ID world, when we are managing with the surgeons and everybody else, we like do drain checks. Sometimes the drains can get clogged. So like changing drains out to drain the abscess properly. So there's some tricks to the drain too, because some of our patients end up having these drains for a prolonged period of time. It's working, you might have to do some adjustments and keep an eye on things.
Yeah, and you can do like an abscessogram. You can do like they will do that under fluoroscopy, right? And then they'll see, is it in the right location? Is it draining? Is it kinked, or is it clogged? Is it not working? But generally you'll leave it in until it's no longer draining and then pull the drain out.
So factors influencing outcomes, image-guided percutaneous drainage. So this was a really nice study, just wanted to highlight it, just talking about how doing interventional radiology draining really helps. So they looked at 143 patients, 104 people were included in the study. And they looked at draining the abscesses. How did the patient do, right? And they followed these patients up to 1 year after the draining. And basically they were able to show by doing just the drainage, over 85% success rate in curing the abscess. So of course, one of them, and then, single abscess. So multiple abscess sometimes gets complicated, but you have just one abscesses, you have over 91% success rate in 10 weeks. So drainage is really important. Working with IR drainage is really important. And then just keeping a close eye and making sure we always do this when there's these abscesses before we stop things, we take pictures again.
Yeah.
Yes.
Yeah. That's a good point. So the question that we get a lot is, how long do I treat? And then they'll say a hepatic abscess, or how long should I treat a renal abscess? And with all of them, or a lung abscess, a brain abscess, and with all of them, the question is, not all abscesses are the same. Some are very tiny, some are very big. And basically, the larger it is, the more likely you're going to have a drain placed. And the smaller it is, the more likely antibiotics without a drain would work. But I always ask the interventional radiologist if they can reach it and drain it, because that would be ideal. But really, because not all abscesses are the same, the best thing to do is, instead of just choosing an arbitrary, number of weeks to treat, it'd be give antibiotics and then re-image at some point, and then ensure resolution, ensure it's going away. So it depends. So if it's very large, I might wait 4 weeks or so.
Yeah. So it definitely depends. If it's like a tiny little abscess, you might be okay. But liver, kidney, all those type of abscesses, we follow re-image before we stopping.
Yeah, because if they come back in and it's larger, then the question is going to be, did we get, was IR able to identify an organism, or do I have an organism in the blood that I can implicate? So did I have the right antibiotics, or was it getting better and then we stopped antibiotics and it got bigger? So it's better just to follow it until it's gone. So hepatic abscesses, so if they come in with right upper quadrant pain, tenderness, and then they may or may not be having fever. And when majority of abscesses involve the right lobe. So will the interventional radiologist be able to reach that spot? Hopefully they can, and hopefully they can drain it, and then give you an organism and identify something.
So just like kidneys, liver abscess also you have to treat for a longer period of time. These are, especially the liver is such a vascular organ with good blood, and bacteria loves that space. So reimage, make sure it's cleared before you stop anything.
Yeah, and another question we get is, do we have to give IV antibiotics or can you give PO?
Yeah.
And it depends.
Yeah,
Yeah.
it depends on the bioavailability, susceptibility, and I have done oral as long as it's susceptible. Yeah.
Yeah, and again, the bigger it is, was it drained or not?
Yeah.
So if it's really large, pill or IV antibiotics might not work, but if it's been drained, it'll probably work whether you give pills or IV or what you do. Abscess, and these are success and failures of abscess and drainage.
Yeah, and a lot of times, if you drain later, if the abscess size is larger, and you didn't drain, so a lot of different factors, but it just right here for you all to look at later, but important to intervene earlier.
And then cholecystitis, we've talked about a little bit. Ultrasound is the best imaging technique to do first. And then for acute cholecystitis, you can have antibiotics stopped within 24 hours, unless there's, unless it's a complicated infection. And appendicitis, if it's, so patients with perforated appendicitis undergo appendectomy. So it's 2 to 4 days of antibiotics after surgery. And there was another trial that looked at 4 versus 8 days, and it found them to be the same.
Yeah, so again, if you have perforation, you do depending on the infection site, 4 to 7 days. If you don't have perforation and it's clean and you cleaned everything out, you could stop within 24 hours. And,
this kind of highlights what we were talking about earlier when it comes to the size of the abscess. Now they were looking at the size of the abscess and do antibiotics alone work, or do you have to do percutaneous drainage? And really, whenever it comes to any abscesses, I will always ask the interventional radiologist, because they've gotten so good now at getting these.
Yeah.
And if they can identify what it is, that would be the best thing, because then we don't have to give them broad antibiotics. We can target it and everything. But yeah, the larger it is, the more likely it's going to need drainage. Yeah. All right.
That's it for today. Any questions or concerns we could answer today about this webinar topic?
Yeah, it's a really big topic. We tried to hit the major points, because it's also extremely common.
Yeah, I would say one of the major things are like covering appropriately, not needing too long, shorter is okay, and making sure we use our IR colleague, and also if it's not perforated and you have good source controls, you could even stop antibiotic within 24 hours. So,
all right.
Thank you all.
Well, if you have any questions, you can always email us, and we're always available for any phone calls at any time. All right. Thank you so much, everybody.
Thank you. Appreciate everybody.